Thank you very much, Adam. It's an honor to be here to show some cases and present some nice slides to your group. And thank you very much for the kind introduction. Thank you very much for the opportunity. And I'm very happy to have you as a friend. We did some work at shop, and I enjoyed working with you. And I'm not sure if you can see my screen, and can you hear me well?
I can hear you. I see all the tabs and everything. Yeah.
Okay. Yeah. All right. So I have never done this before. I'm going to be showing slides and then cases. I hope it works. If it doesn't work, I will just jump into slides. So this presentation is targeted to the neuroradiology fellow and the radiology resident, and the main goal is to increase the awareness about the multitude of pathologies that can occur in the posterior fossa, the multitude of tumors that can occur in the posterior fossa. And we have the usual suspects, right? We have the big five, and this is just to show that the big five is the medulloblastoma, pilocytic astrocytoma, and then we have the brainstem glioma, ependymoma. ATRT is a very rare, but is the most common of the rare ones, and the others can reach up to 15%. So, and I would like to show some examples of these others, and I will show typical examples of the main five. Okay, and I can't pretend that I'm a pathologist, but this is just to show how the big five look like in the microscope, and the way the cells and the parenchyma, the background appears, and it has a very good correlation with imaging. Okay, so here you have the pilocytic astrocytomas. The cells are sparse, and there is a lot of interstitium between the cells. So this accounts for the lack of diffusion restriction that we see on pilocytic astrocytomas. And here we have the ATRT, the very ugly tumor. You see a lot of cells, and in comparison with pilocytic astrocytoma, the interstitium and the space between the cells are markedly narrow, right? And here we have also medulloblastoma that also shows narrow, decreased amount of interstitium between the cells, and the cells are densely packed, and there is the cytoplasmic nuclearation is small. So this is something that explains the signal, especially diffusion. And here we have a ependymoma that it lies between these ugly ones, and the diffuse midline glioma that it's resemble somehow pilocytic astrocytoma. They usually have similar T2 signal, and they typically do not show diffusion restriction. Okay, so this is just to show and to explain how these lesions appear in T2 and diffusion. And I will skip that, and I will show you some cases. Let's see if this can project well. So let me see, I will enter full screen. So this is a case that I had when I was working in the Children's of Brasilia. And in Brasilia, there is a small population of indigenous. They live in the outskirts of the city, so there's a tribe there. And this baby, this kid, went to the hospital, and we had the scan, okay? And what is important here is to see, to look at the T2 signal, okay? So this is a markedly hypointense T2. And when you see markedly hypointense and there is no diffusion restriction, or maybe in the periphery, a little bit of signal there. But you start to be feel puzzled. What is this, right? Because this doesn't look like a medulloblastoma because there's no diffusion restriction. This is not an ATRT, no diffusion restriction, but it doesn't look like a pilocytic astrocytoma, right? It doesn't look the typical astrocytomas that we see in the posterior fossa, and the lesion is enhancing peripherally, right? And the patient was done under anesthesia, and part of this is opacity due to atelectasis, and part of this is infection. So I think you know already the diagnosis based on the imaging findings and the lung opacities and the multiplicity. So the lesion, the patient also had a small lobulated lesion in the left occipital lobe. So this is, I have this hidden here. I hope you see it now. So this was a tuberculosis, like a tuberculoma in the posterior fossa with an additional lesion in the left occipital lobe, okay? So this is a case that I would like to show. I will try to show more cases. Let me see if I can skip this. Yeah, view. Let's exit. Maybe it's going to take too much time. I think Adam gave me 3 hours to speak about posterior fossa tumor. So this is another case, okay? And this is a typical case. And the reason I'm showing this is this lesion can look heterogeneous. And this is a mimicker in terms of diffusion, because you can have areas of diffusion restriction. You can have areas of blood calcification. It usually enhances heterogeneously. But this tumor typically does not show as much diffusion restriction as the ATRT and medulloblastoma, okay? And in my experience, maybe you have the same experience. I have never seen this tumor arising in the cerebellar hemisphere. And I have never seen this tumor arising from the pons or the brainstem, okay? So they typically arise in the fourth ventricle, or they can also arise in the Lucica and Magendie foramen. And it has this typical plastic appearance, filling up the fourth ventricle and going through the outputs of the fourth ventricle. And it can reach also the upper cervical spinal canal. So this is a ependymoma, typical ependymoma. The patient was 17 years old. So this is a typical presentation. You should not expect homogeneous T2 signal. You can have cysts, you can have calcification, and those tend to cause heterogeneity, and they tend not to show as much diffusion restriction as ATRT or medulloblastoma. Okay, so I'm going to close this one and hit here. Let me show this one. And this is also a typical case of an uncommon condition in the posterior fossa. And the books say that you have a feather type of enhancement. So you have you can hallucinate a feather here, or a paintbrush, like a paintbrush, right? And this is what I found the most useful imaging feature to at least think about it, because the rest of the imaging findings are very similar to a pilocytic astrocytoma. Okay, and as a pilocytic astrocytoma, these tumors, they show the cotton ball appearance, like very bright T2 signal. Obviously, they don't show diffusion restriction. And on flare, they are hyperintense. Depending on the degree of cystic changes, they can be more hyper in flare. okay? And obviously they don't show diffusion restriction. And again, textbooks and articles say that if you find this, it helps in the differential diagnosis. So this is a posterior fossa cerebellar vermian ganglioma, okay? So the take-home message here is the paintbrush or the feather type of enhancement, okay? Let me see another one. Let me show you the following case. And this is a similar lesion. And this also has a cotton ball. This has a little bit dirty cotton ball, but T2 is very bright, okay? And the lesion is exophytic from the dorsum pons. And you have this peripheral enhancement, and obviously very low values, sorry, very high, high values in the map. So it means that there is no diffusion restriction in the tumor. Again, flare is hyperintense. So this is a typical pilocytic astrocytoma originating from the dorsum of the pons and filling up the fourth ventricle. Okay, so this is a pilocytic astrocytoma. And the home message, the take-home message here is if you see a cotton ball, very bright nodule like this, it means that this is not medulloblastoma. This is not, or very likely not an ependymoma, likely not ATRT. So you are probably dealing with pilocytic astrocytomas or other not so common pathologies. Okay, so that's the take-home message about this case. Let's see another one. This following case it's part of the Big Five, okay? And this one I don't have the molecular diagnosis, but it's a lesion that is arising in the midline, and it's arising from the vermis, okay? The fourth ventricle is compressed here. So it means that ependymoma is very less likely, right? The lesion is showing increased DDRBY signal. And here in the exponential map shows that the lesion is showing diffusion restriction, okay? Very bright diffusion signal, marked diffusion restriction. And the lesion is heterogeneous enhancing. And you have this, this is something that I didn't coin. I learned this from Dr. Voslug. And it has this Thousand Island appearance, like small cystic in the middle of the middle of the tumor. So whenever you have this Thousand Island sauce appearance, it points, or it makes a medulloblastoma in your top differential. So this is a pathology proven medulloblastoma. I don't have molecular diagnosis, but you know the take home point message here is when you have this marked diffusion restriction, embryonal tumors should be in the top of your list of differential diagnosis. And this is too much low signal for a pilocytic astrocytoma. Okay, pilocytic astrocytomas, they tend to have a very much brighter signal. Okay, any enhancement, it's not a good feature. It's not a differentiating feature. Okay, so T2 is important. Location outside of the fourth ventricle. The lesion is pushing the fourth ventricle anteriorly. It's not arising from it. Okay, you can see this, that the fourth ventricle is compressed. And the fact that there is diffusion restriction makes embryonal tumor most likely diagnosis. Okay, let's see another case. I wish this transition was softer. And this is also a very interesting case, and I'm just showing T2 and diffusion and ADC map. In my experience, this is something that it's not published yet, but at SHOP, when we measured the ADC values of preoperative cases of diffuse midline gliomas, so we segmented all the tumors, and we never had diffusion restriction. So when you compare the ADC in the abnormal signal area in a diffuse midline glioma, they always have similar values as the remaining of the brain. So in our experience, we never saw a diffusion restriction, the diffusion restricting diffuse midline glioma. Okay, so the reason I'm saying that, because I'm going to show you some examples of diffusing restricting brainstem lesions that were of different pathology. Okay, and what is typical for diffuse midline glioma is the fact that these tumors, they tend to invade the more than 50% of the cross-sectional area of the palms, which are the most common location. They can grow so large to the point that they can encase the basilar artery. Okay, and enhancement it tends to be very minimal. They can enhance, but enhancement it's not marked in diffuse midline gliomas. Okay, so this is a pathology proven diffuse midline glioma in a teenager patient. So let's go to the next case. This is a so here, this is a very intriguing case because it's super heterogeneous, okay? And the patient had hydrocephalus. And you see this large mass, okay? And there is a component of the mass that is extending into the spinal canal and deviating the spinal cord, the medulla to the right. And there's this marked nodule of low signal. And this is not typical for a diffuse midline glioma. And when you see gradient echo, this is an old case, and you see there is a just big chunk of calcification. And again, this big chunk of calcification is not common imaging finding in diffuse midline glioma. Okay, very, very low signal. And let's see if I can show you how this enhances. There is, let's see here. There is this peripheral enhancement. It's too much enhancement as well for a diffuse midline glioma. Let's see if I can show you diffusion imaging. So there are some areas of increased signal, but I think this can be also due to the susceptibility artifacts. And this is a pathology proven brainstem ganglioma. Okay, just to show you that in this case, we don't have the feather appearance of enhancement. And what is telling us that this is less likely a diffuse midline glioma is the fact that there's a big chunk of calcification here. So this is not typical for a diffuse midline glioma, okay? So just to show you how can you reach or increase your differential diagnosis when you face a lesion like that. Okay. It's another one. All right, so yes, this is a great case, and I'm sorry I don't have them hanged properly. Let's see this. You see that the lesion is necrotic. It's located in the dorsum brainstem, and the enhancement is heterogeneous. There's an area that is showing lack of enhancement internally. And let's see T2. On flare, the lesion has you can see that there is a level here of hemorrhage. This is very not typical for diffuse midline gliomas. Diffuse midline gliomas, they can have bleed, but I mean, this is not a typical presentation in diffuse midline gliomas. And let me show you the ADC map. You see there is an area that is showing diffusion restriction in the periphery of the lesion. So when you see a lesion that may represent a diffuse midline glioma, but it shows this marked diffusion restriction, you see blood, it's very aggressive. Diffuse midline gliomas, they are aggressive, but they don't look ugly like this one. So you need to think of a embryonal tumor. And this was a pathology-proven tumor, okay, embryonal tumor with multi-layered rosettes in the dorsal brainstem. Okay, so take-home message here is the presence of a very ugly lesion with diffusion restriction and even layering of blood. So this is very less likely a diffuse midline glioma, and embryonal tumors arising in the brainstem should be in the top differential diagnosis. Okay, let's see if we have another case that can help you. Yes, so this is a very interesting case as well, and the lesion is very heterogeneous, multicystic. Diffuse midline gliomas, they can have cysts, but they are not like this. They are not like multicystic, and the architecture usually is preserved. So if you have a diffuse midline glioma, they expand, but they don't degrade. They don't make this mess in the structure that he is in, or it is in. Okay, so you see cysts, necrotic, fossae, very heterogeneous appearance. You see the normal architecture of the medulla and the inferior pons is lost. Let's see here. Let's see. I don't have all the sequences, but just to show you how diffusion looks like. Okay. There are some areas of increased signal, but these were not diffusion restriction based on the ADC. So this is not a typical diffuse midline glioma, and this is a pathology-proven brainstem ganglioma as well. And in this case, unfortunately, we don't have the feather appearance, the paintbrush appearance, but just to show you that diffuse midline glioma, less likely in this case due to this heterogeneous appearing tumor with multicystic appearance. Okay, let's see if we have another one to highlight the typical appearance of diffuse midline glioma. Yeah, so this is a sagittal T2 again. You see, the pons is abnormal, but you have this multiple cystic structures, multicystic, and you don't appreciate the normal architecture of the brainstem, as we saw in that example. So, can this be a diffuse midline glioma without treatment? Very less likely. Let's see diffusion. This is the ADC map. And you see the values are very similar to the rest of the parenchyma. So not showing diffusion restriction. And enhancement is heterogeneous. There's a nodule here and non-enhancing cystic structures in the periphery. So this nodularity, not typical for diffuse midline glioma. And this is a pathology-proven pleomorphic central astrocytoma of the brainstem. Okay, I'm not sure if there is a pathognomonic imaging feature pointing to pleomorphic central astrocytoma, but the point is this can cannot be a diffuse midline glioma. It can be a pilocytic astrocytoma. In this case, was a low-grade astrocytoma, but very less likely this is a diffuse midline glioma of the brainstem. Okay, let's see another example here. This is also an old case, and this was a time when this is before WHO 5. So this is a case from Brazil, and this case this tumor is very heterogeneous, as you can see. It's very the right cerebellum looks fairly normal, but the left side usually it's very heterogeneous. There's this mass with the center that is showing increased signal on flare. There's a big amount of blood within the lesion, so it's a very aggressive lesion, necrotic with blood. And let me show you that there is a peripheral enhancement, but the center of the lesion is not enhancing, so it's a very necrotic lesion. And just to show you ADC, so there are some areas that show diffusion in the restriction in the periphery. This may be just due to the blood. Okay, so it's a very aggressive, very ugly looking tumor. You should never see this in a pilocytic astrocytoma because of the diffusion restriction. Okay, this can be seen occasionally in medulloblastomas, but it's not typical to have this marked necrotic lesion with blood, but it's possible. But in this case, this was a before. This is like an adult, early adult, a young patient with a GBM, a high-grade glioma in the left cerebellar hemisphere. Okay, just to show you how. What is pointing towards a high-grade glioma instead of a pilocytic astrocytoma is the presence of lack of bright signal in T2. So we don't see the typical T2 signal. The lesion is obviously showing marked diffusion restriction in the periphery. It's a very ugly necrotic, infiltrating the entire cerebellum. Okay, so these are features that you normally see. We normally don't see in a pilocytic astrocytoma, so pointing to a more malignant mass. Okay, so this is a pathology-proven high-grade glioma, a GBM in the cerebellum. Let me show you some other case here. CT, it's very important, even though it's not necessary. But this is a pathology-proven pilocytic astrocytoma. And you see how hypodense the mass is. This is very less likely an ependymoma, because ependymomas, medulloblastomas, they tend to have higher density on CT. Okay, so CT helps. It's not obligatory, but if you have a previous imaging, previous CT from elsewhere, it helps you it helps in terms of presence of calcification, presence of blood. And when you see a hypodense mass here, it points toward, in the group of pilocytic astrocytoma, it points towards a low-grade astrocytoma. Could also be a ganglioma as well. Okay, so this makes ependymoma or a medulloblastoma low in the differential diagnosis, and as well as ATRT. Very unlike you see an ATRT so hypodense like this. Okay, so this is a pathology-proven pilocytic astrocytoma. Let's see if we don't have the MRI of this patient. So this is another, just to show a very large pilocytic astrocytoma. Just please see how these lesions are hypodense, okay, on CT. Very less likely a medulloblastoma, ATRT, or even ependymomas. You tend to have higher density in those cases. Almost finishing those cases. And this is the companion MRI on that case that I just showed. Can this be a medulloblastoma? Sorry, can this be an ependymoma? Probably not, because the lesion is not arising in the fourth ventricle. The fourth ventricle is compressed, as you can see here. It's not originating from the fourth ventricle. And can this be a medulloblastoma? Less likely, because you see, there is the cotton ball, the big cotton ball here. The cotton ball can be heterogeneous, can be homogeneous. You can have a quote-unquote dirt cotton ball, but it's still a cotton ball, right? And this is a very large cotton ball with some areas of heterogeneity. So when you see this cotton ball here, pilocytic is possible. And you have like more rare pathologies that can give you this appearance, such as pylomyxoid astrocytoma. Even gangliomas can look like that, okay? So with this diffusion restriction, less likely a medulloblastoma. You tend to have similar values as the brain in ependymomas, and sometimes we see some voxels showing diffusion restriction, but virtually all the voxels here in this tumor, they show high values in the ADC. So pilocytic astrocytoma is the most likely diagnosis in this case. And contrast in pilocytic astrocytomas, they can be everywhere. They can be heterogeneous like this. They can be homogeneous. You can have a center without showing no enhancement. You can have a cyst with a nodule. So enhancement is not a defining feature of a pilocytic astrocytomas because they can be all across the board. Okay, so this is a pathology-proven pilocytic astrocytoma. It's a large one. Just please remember the cotton ball appearance of a pilocytic astrocytoma. And this is another cotton ball. Okay, a cotton ball that you have this, the fourth ventricle is here, and there is this exophytic mass arising from the dorsum brainstem, arising from the medulla, going upwards, and it's going downwards. You have the cotton ball, but you know this appearance. You need to think about ganglioma, because they tend to occur in the dorsum brainstem with this exophytic component. Okay, maybe you can hallucinate here, like a feather, a paintbrush. So this is a pathology-proven ganglioma. And the cotton ball, it's not exclusive of pilocytic astrocytomas. They can occur in gangliomas as well as like that. They can occur in those very heterogeneous xanthosarcomas. So, but this can never be this can never be a ependymoma, because the lesion, even though it's filling up the fourth ventricle, but at the center of the lesion, it's an exophytic lesion arising from the medulla, and there is a component going into the spinal canal. Even the spinal cord, and even the spinal canal is widened by the slow growth pattern of the lesion, right? So this can never be an ependymoma. This can never be a medulloblastoma. So it is appearance, most likely, and that's what it is. The patient had a ganglioma arising from the cranocervical junction and filling up the fourth ventricle. And just to show you, like a odd cotton ball, because there is some calcification. There is a component that is showing a hypointense signal, but there are components of the lesion that show cotton ball, like very dark. When I meant to cotton ball is that you see a very bright nodule or a component in the matrix of the tumor, and this tells you that, oh, this may be a pilocytic with a heterogeneous appearance. Okay, and again, the calcification is very heterogeneous, and in this case, the periphery is enhancing and the center is not. Let me see if we can have, if I have here diffusion. This is an old case, so I don't have a map here, but just to show you, this is not a good case because I don't have the ADC. I just believe me. This is a pathology-proven pilocytic astrocytoma arising from the cerebellum, the midline, with a component compressing the fourth ventricle. Okay, so just to show you that life is not easy, and you may not see cotton balls everywhere, but just to remember that, you know, there's a destroyed cotton ball here, maybe like in the periphery. I know that this is disturbing because the signal is too hypointense, but probably this is a calcified component of the lesion. But in the periphery here, you see the very bright. It's not as bright as the cystic component, but it's much brighter than the adjacent cerebellum. So this is in keeping with the pilocytic astrocytoma, or as I mentioned, ganglioma can occur like that too. And less likely, this can never be a medulloblastoma due to the fact that there is no diffusion restriction, and there is a component that is very bright on T2, and the lesion is can never be an ependymoma because the lesion is not in the fourth ventricle, right? The lesion is intraaxial and compressing the fourth ventricle. Even the tonsils are herniating inferiorly, right, to reach the upper cervical spinal canal. And this is the second to last case. This is important case. This is a very rare tumor. They can be heterogeneous like this. But please pay attention to this detail that the lesion is, there is a dural base component. So, and there is a component of the lesion that shows increased signal. And believe me, this was showing diffusion restriction. And a solid component, which is enhancing, it's very, has low signal in comparison, for example, what you normally see in pilocytic astrocytomas, right? So it's dark in terms of T2 signal. There is obviously this cystic component, necrotic component in adjacent to it, but the nodule showing enhancement and diffusion restriction is very hypointense in comparison with what we see in the cotton ball, right? Can this be a medulloblastoma? Yes, it can be. Can be an atypical meningioma due to the extensive dural base component, right? This can also be an ATRT due to the fact that the patient, the lesion is showing some diffusion restriction. But this is a pathology-proven Ewing sarcoma. Okay, so this is just to add this to your list of differential diagnosis. Ewing sarcomas, they are typically extraaxial. Eventually, they can occur intraaxially. I've never seen one, and I don't have a lot of experience in Ewing sarcomas because they are super rare, but they tend to be extraaxial, like this one. They tend to show diffusion restriction. The diffusion restriction, like this, it's not typical for meningiomas because meningiomas, they eventually show diffusion restriction, but it's not as marked as this one. And in kids, please think when you see a diffusion restriction lesion located extraaxially, please add Ewing sarcoma in your list of differential diagnosis. And my last example here is this one. It's an extraaxial mass. It's a more homogeneous lesion that we saw previously. Okay, and most of the lesion is showing similar ADC values to the cerebellum, but I'm not sure if it projects well. But if you measure this in comparison to the cerebellum, there are areas of diffusion restriction, right? Especially when you compare with the adjacent temporal lobe, you can see that this extraaxial mass is diffusion restricting, and the lesion is clearly extraaxial, right? This vessel is displaced, and in this particular case, there is a large dural base, and this was also a pathology-proven Ewing sarcoma. Just to give you some examples of extra-axial masses in the posterior fossa. Okay, so with this I conclude my cases, and I can go back to the slideshow. Just take some water. So I think we have commented and shown, seen a lot of medulloblastomas. Just to remember that you have 4, I mean, depending on the article, in there 12, but according to the WHO, you have the WNT activated sonic hedgehog, and according to TP53, they can be wild type and mutant, and you have the non-Wnt and non-sonic hedgehog. These are not pathognomonic, you know. But I mean, the Wnt activated, they tend to be peripherally located. They tend to be in the cerebellopontine angle system. As sonic hedgehog, they tend to be in the cerebellar hemispheres, and the non-Wnt, non-sonic hedgehog, they tend to be in the midline, okay, in the vermis. And this is again a similar typical medulloblastoma showing diffusion restriction. Enhancement can be very minimal, like we are seeing here. Okay, and the lesion is in the 4th ventricle, arising probably from the left side, filling up the 4th ventricle. So this is a pathology-proven medulloblastoma. And again, other example of parasitic astrocytoma. They never cause diffusion restriction. Okay, enhancement can be nodular, and remember the cotton ball appearance, very bright signal. Okay, typically, you can always have the atypical cases, but this is the typical presentation of them. This is a companion case. This is a pilomax myxoid astrocytoma. Imaging-wise, they are very difficult to differentiate from parasitic astrocytomas. It's very challenging. They tend to show more leptomeningeal deposits, but leptomeningeal deposits can also occur in parasitic astrocytomas. So it's very difficult to differentiate them apart. Usually the differentiation is made by the pathologist. So just to show you that this can never be a ependymoma due to the signal and also the location, right? And this can never be a diffusion risk, can never be an embryonal tumor due to the lack of diffusion restriction, right? And the enhancement is, in this case, was peripheral with the center that is showing on enhancement. We cannot forget about this entity. You see what is telling us that they tend not to show diffusion restriction, as we see here. And what is most important here is the fact that we see a lot of flow voids within the lesion. Of course, the clinical picture may be associated with von Hippel-Lundau, and they are typically show marked diffusion restriction. If the patient has VHL, these lesions, they tend to be multiple in the periphery as well. They can be small, like tiny nodules with evident enhancement. And if they are large enough to show vessels, that's the typical presentation. You have this flow voids within the tumor. Okay, so this is the typical amyloblastoma. This is very interesting because it looks like a tumor. It looks like an infiltrative mass, but there is no diffusion restriction, no contrast enhancement. And what is important here, the take-home message, is this disorganized foliation. You see the normal folia of the cerebellum here, and you see this plastic cerebellar hemisphere on the left, as if this was like a polymicrogyric, quote unquote, cerebellum. So this is a case of dysplasia of the left cerebellar hemisphere. So you see there is a lack of gray-white matter differentiation. The lesion, the entity is associated with lack of this distinction between cortex and white matter in the cerebellar folia. So this is the typical presentation of this plastic cerebellar hemisphere. So this is the limite du clos, and typical appearance, this corduroy appearance, right? Like a laminated. They can eventually resemble a pilocytic astrocytoma or a benign or low-grade astrocytoma in the cerebellum, like this. So in this part, so they have two cases here, and in this case, this plastic gangliocytoma has not the typical appearance of lamination or the corduroy appearance that we typically see. Okay, they can be very non-specific like this one, and very specific as this companion case. Okay, this is another tumor, another entity, a rare one that can occur in the posterior fossa. They resemble the ganglioglioma, but the fact that you see satellite lesions, it's in the midline. Usually these lesions are in the midline. The rosette-forming glioneuronal tumor, they tend to midline, they tend to be in the vermis, and they tend to occur surrounding the fourth ventricle. So, but the most important feature here is the lack of diffusion restriction. Enhancement is variable. We can have this nodular enhancement, central lack of enhancement, but the multiplicity and the location surrounding the fourth ventricle are the most important imaging features of this entity, rosette-forming glioneuronal tumor. Obviously, cavernous malformations, cavernomas, they can occur in the posterior fossa. It's hard to give this to give the diagnosis upfront before surgery, because this can the air fluid level. The fluid levels can occur in other other malignant tumors, but you eventually will be seeing those leading cavernomas. And the fact that there is a peripheral flare height cap may be a feature that resemble. It's a feature that may point to cavernous malformations, especially in T1, like this, what we are seeing in the periphery here. It's another feature of cavernous malformation. I have another case of cavernous malformation, maybe in the presentation, which has a better, which has a more typical appearance. I hope I have time to show it. And this is another case of an ependymoma. They are typically in the posterior fossa. They have the plastic appearance. If they are large enough, they can grow and extend into the spinal canal and also to the cerebellopontine system. And just to show you that you see there is no cotton ball appearance. This T2 signal is darker than the cotton ball appearance that we see in the pilocytic astrocytomas. ADC and the DWI are important because you can have diffusion restriction in ependymomas, but they tend to have, in comparison with ATRTs and medulloblastomas, they tend to have less diffusion restriction. Of course, there are overlapping cases in which it is impossible to tell, but typically they don't show as much diffusion restriction as a typical medulloblastoma or a typical ATRT, as we can see here. But obviously, the ADC here is completely different from a typical pilocytic astrocytoma. So it's easy to differentiate ependymomas from, when I say easy, I mean most of the times it's easy to separate an ependymoma from a pilocytic astrocytoma based on ADC values. And this is a very typical case. It's a very odd location, but this can occur, okay, in the posterior fossa. The imaging appearance is this one. You have the cauliflower appearance. Choroid plexus papillomas, they are very rare in the posterior fossa, but they can occur They can occur obviously in the fourth ventricle, but the location that has most choroid plexus in the posterior fossa are the Luschka foramen. So they tend to be offline, off midline, like this one. And you have this vessel with internal vessel with a cartwheel. I mean, you have the center vessel with projections extending from the center. They tend to enhance avidly, but you see these microlobulations, like in a cauliflower appearance. So this is a typical imaging feature. And depending on the degree of calcification, you have this speckled diffusion signal, and they never show diffusion restriction. You see, they tend not to have diffusion restriction. This is a very low signal on trace, and they don't show diffusion restriction. You may eventually have blood, which can disturb the magnetic field, and you can have a low ADC value, but it's due to the blood, not to the intrinsic properties of the tumor. And they can be very can be very high isodens in comparison with the adjacent brain. They can have marked calcification. They can be very dark, very dense chunk of calcifications. But again, typical appearance is this laminated, like a papillary projections, and these cauliflower appearance. This is a typical case of choroid plexus papilloma in the posterior fossa. I have never seen a case of carcinoma in the posterior fossa. They occur. There are probably 3 or 4 cases in the literature. So they are very rare, very uncommon in the posterior fossa. The choroid plexus tumor that occur most commonly in children is a papilloma rather than a carcinoma. Again, similar case. It's a more typical case of a diffuse midline glioma. In our experience, these lesions do not show diffusion restriction before treatment. And this is the typical appearance when they embrace and encase the basilar artery. Enhancement typically is very minimal or patchy, like this one. Okay, and you have this striped appearance. So this is a typical case of diffuse midline glioma arising from the pons. Again, I think this is the same case that I have shown. So I just skip that. Similar case, the nodularity, very atypical for a diffuse midline glioma. So I skip that one. I have shown this before. Another potential differential diagnosis for diffuse midline glioma in the brainstem is the angiocentric glioma. What tells us that this is less likely a diffuse midline glioma is the fact that there is a large cyst within the lesion. Okay, you can have cysts, small cysts in diffuse midline glioma, but this is very atypical. You know, they are homogeneous with no cystic changes. Okay, unless this is treated. Okay, and as we expect, these angiocentric gliomas, they do not show diffusion restriction. Okay. Okay, so this is a very interesting case again, just to show you that when you see a lesion that shows diffusion restriction, there are some areas that show diffusion restriction. Okay, this is in the upper cerebellum on the right, affecting also parts of the vermis, and the fact that there is this diffusion restriction, it tells you that it may be this can be a medulloblastoma, this can be another embryonal tumor, but the lack of the cotton ball, the presence of diffusion restriction, and makes this less likely a pilocytic astrocytoma. Okay, so when you see a lesion that shows diffusion restriction, it's either, so this is not in the fourth ventricle again, so this is less likely ependymoma. So it's likely you are facing with a high-grade lesion, either an embryonal tumor or in this case, a high-grade astrocytoma. Okay, so diffusion is very important to give you the maybe not the specific pathology, but to narrow the differential diagnosis. So we were missing this entity. This is a very interesting case. You can see that the lesion is very bright on trace, and it is showing diffusion restriction, as you see here. Okay, so obviously this cannot be a pilocytic astrocytoma. The lesion is arising in the vermis, the cerebellum, with affecting the superior portion of the cerebellum on the left side. It's not arising in the fourth ventricle because the fourth ventricle is deviated to the right. So it's an embryonal tumor, and in this case, a young patient, 13 months. This was a pathology prover, ATRTs. Based on our experience, it's impossible to differentiate ATRTs from medulloblastomas based on ADC because they have overlapping characteristics. So you need to rely, if you want to give a precise diagnosis, maybe age can help, but age as well is very there's an overlap. So it's hard to separate this ATRT from medulloblastomas or other embryonal tumors. But the ependymomas and pilocytic astrocytomas, they can be excluded here due to location and ADC values. And I have shown this case before, so just to remember, embryonal tumor showing diffusion restriction, marked low values in the ADC map. So this is a usually benign, mostly benign, the low-grade gliomas that occur in the tectal plate. When I was a resident, these are majority of, at the books, they say, oh, this is always benign, but the more research has done, these lesions can grow, they can metastasize, and you can see also high-grade lesions affecting the tectal plate. So it's important follow-up, it's important early diagnosis, and sometimes these tumors, they need to be biopsied. Okay, so but this one is a fairly benign, stable tectal plate glioma. Obviously, no diffusion restriction is seen. I'm almost finishing. This is a patient with Faces syndrome. This is a tiny hamartoma, so they can occur in the posterior fossa as well. Okay. Another case, very interesting, very rare. Obviously, history is important. Usually, patients have leukemia, or not usually, but these are patients with leukemia, so the history is important. And imaging-wise, they can occur, as you can see here, everywhere in the posterior fossa. They typically show diffusion restriction, and they typically are extraaxial in the periphery of the cerebellum. They typically are attached to the dura. They can be attached to the dura, or they can be in the leptomeninges. And they show very low signal on T2, dense on CT, and there are some areas of these lesions that show diffusion restriction, as you can see here. And diffusion is important because you don't see this lesion quite well in T2. It's embedded here. It's hard to see. Maybe here you see it. After contrast, you may not see it, but diffusion can show you that instead of this large one, the patient has another one, like a multiple. And the multiplicity as well is an important feature that can occur in pleuropelma. This is a patient with lymphoma. Lymphomas, they tend to be in the periphery, as in other parts of the central nervous system, they show this nodular enhancement with diffusion restriction. Adam, I'm 2 minutes after my time. If you just let me know if I still have some slides to show, or should I finish it? Just please let me know. You are the master, so you tell me what to do. I still have some.
You're almost done. How many more slides do you have?
Well, I have let's see, 77. I have probably or nine slides, but I mean, I mean, I can jump into the conclusion because I'm almost finishing the tumors. I have an abscess to show, and let me just show 3 more examples, and I can wrap up.
Okay, sounds good.
Okay, sorry to take too much of a time. So this, I was telling this is a lymphoma. Yeah. So this is just to show that metastasis can occur. So this is a neuroblastoma metastasis. Okay, they tend to be hemorrhagic, as you can see. We cannot forget about the diffuse leptomeningeal glioneuronal tumor. You have this quote-unquote cystic lesions that populate the leptomeninges. They can enhance. They can be devoid of cysts. They can present as if this patient had tuberculosis, for example. So this is a typical case in which we see dissemination of these small cystic lesions, also involving the spinal cord, and they typically do not show diffusion restriction. And enhancement is variable, so don't forget about the diffuse leptomeningeal glioneuronal tumor that occur in the posterior fossa. Obviously, we could not forget about the endolymphatic sac tumor. Again, this is a feature present in the von Hippel-Lindau syndrome. Obviously, this is an extraaxial lesion arising from the Peter's bone. So these lesions, they tend to enhance avidly. Okay, you have this mottled, destructive, lytic, moth-eaten pattern that is centered in the endolymphatic sac. So typical case of an endolymphatic sac tumor. Again, I have shown just this case, so I don't need to show it again. Obviously, these patients, NF2 patients, they can have meningiomas like this one, and the meningioma is extending into the jugular canal. Okay, so this is a typical meningioma with a lot of periosteal reaction. You see that the lesion is centered, and it's in the cerebellopontine angle cistern with a dural-based attachment, and the lesion does not show diffusion restriction. In kids, you cannot forget about Langerhans cell histiocytosis, a typical location of Langerhans cells and deposit, so destroying the entire temporal bone, and they can eventually extend into the posterior fossa. Okay, Langerhans cell histiocytosis. I've shown this case before. Similar cavernoma, another case of cavernoma with a nodularity here that shows hemocytin staining. So almost finishing. So lipomas, easy diagnosis based on CT, T1 hyper, T2 hyper, and devoid of signal when you apply fat saturated sequences. Abscess, obviously, abscess can occur in the posterior fossa. When you see an abscess, look at the temporal bone, because this can be the source of the infection. Okay, typically they show diffusion restriction, as you see here, and in this typical case, it's very thin capsule with a non-enhancing center. So just to conclude, this is a busy slide, but just remember that location is important. Try to establish where the lesion is centered, and from this you can grow in terms of the differential diagnosis. Just to finalize here, location is important. And my last slide is this: just remember what lives in the posterior fossa. I mean, location is very important. Diffusion is very important. T2 signal is very important. CT is very important. Eventually, you need to do spinal imaging when you are facing with the tumors, especially the higher grades. Okay, and you can take a screenshot of this if you want. I mean, I just gave you here like the list of cases in which you see diffusion restriction. Sorry, this is wrong. Leptomeningeal metastasis and so on. And what I tried is to give you like a big menu of pathologies that can occur, masses that can occur in the posterior fossa. I hope this is useful. Not sure if I have time for questions, but if there are no time for questions, I can answer the questions as they appear. Maybe Adam can send me questions
Sure,
from
yeah.
the.
So if you have any questions, feel free to send them to me or email Fabrício. But yeah, happy to pass it along. But yeah, thank you so much, Fabrício. Yeah, I mean, these are some amazing cases. Definitely see a lot of stuff commonly, but you know, some of these cases it can be a little bit tricky, and you know, some pretty incredible cases. So thank you so much, and thanks for breaking it down. I think I'm gonna start using the cotton ball person more now. Yeah. So thank you so much, everybody, and hopefully we'll see you next time. Thank you again, Fabrício, and thank you for everybody who joined. Have a good one.
Thank you very much, Adam, for the opportunity. Okay, have a good night.
You too.
Bye bye.